so many people here, so I really thank you for all turning up, and hopefully we can meet your expectations, whatever they are. So today the proceedings will be over the next 2 hours. I'll give a brief overview of the Epi branch. Then we'll have some other speakers talking about specific areas within the Epi branch where we can help you with accessing injury data. Then we'll have a short break for morning tea, and then we're going to get into more of a workshop where we'll pose you with a question, and you can get into groups and try and answer that question, and we'll get back together and see what you've thought about that and resolve the questions. And it's really designed to get you to think about how you use injury data after you've heard us talk about the resources that are available. So the Epidemiology branch provides population-based information across the whole health system, really. And I guess that's evidence today that there's a range of people in the audience who are interested in using our information. We play basically a surveillance role where we monitor and assess and report on the health status of the population of Western Australia, and also the service utilisation of that population. To do that, we provide evidence to guide policy, identify emerging issues, planning for health services, and also evaluating those health services and system performance. So the tasks undertaken by the branch are obviously very varied, and we need quite a highly specialised and diverse group of people to do that. And so we're loosely organised into three functions. We have a geographic information system group that manage and maintain the spatial information and infrastructure for the whole Department of Health. And Grace will be giving more details about that group and what they've got to offer for people interested in injury. We have two groups which provide epidemiological analysis and information in terms of analysing the administrative data sets that are available within the department, providing information on profiles of health populations, health outcomes, and evaluating health initiatives and system performance. And then we have the survey team, which mainly focus on two distinct surveys. There's the Health and Wellbeing Surveillance System, which is the Population Health Survey, and we'll hear more about that too in our presentation today. And they also run a patient satisfaction survey, which measures the patient experience and satisfaction with health services provided by the department. So you'll hear all the other speakers later in the session elaborate on those areas. So there's a high demand for information, as you'd imagine, from the branch. We actually respond to over 250 individual requests for information a year, as well as do specific projects. And so we really need to be able to respond to those requests quickly and have a good information dissemination system. The way we do that within the department is through the internet and our website. And I'll try and use that as a highlight how we disseminate information. Firstly, we have on our website an area where, once I get the cursor up, we provide you access to publications. And so those people outside of the department are able to actually get publications through the Department of Health website. We'll show you that in a minute. So our key publications, for example, are the Chief Health Officer's Report is our flagship publication, which we do on a regular basis over a number of years. Provides you with an overview of the whole health of the population in which you can put injury into context. One of the big areas that we work on is providing burden disease information, which again helps you put injury into the overall context of all other conditions. most recently we looked at attributing the amount of burden that's contributed by risk factors to burden disease, in which obviously injury is one of the major conditions. And most recently last year we published the Epidemiology of Injury in WA, which is, I guess you could use it as the Bible for reference for information on injury in WA with the most up-to-date information. And as I said, for those who haven't got access to the department's intranet site, you can access all of those publications and other publications that are related to injury that have been produced by the Epidemiology branch through the department's website. Back to the books. Back to the website. We also have a system developed where we're providing online information to the department through our internet, and we do that in several ways. We've got a mapping application which is interactive, where users can actually access maps of boundaries, demographic information, population information, down to the statistical local area level. It has some health information, but it's actually limited in the health conditions that we report there. So we've got another application which is called Health Track Reporting. Oh my God. Health Track Reporting, which is an interactive epidemiological reporting tool, and Alex will be providing detailed information on how that can be used and how external users may get access to that. And the third way that we provide information through the department is using the dashboard or an Instant Atlas off-the-shelf product, where we provide information from our health survey on a regional level of all the information that's collected from the health survey. Also on our website, we have give you an opportunity to request information through our request process. And this is not. Sorry about that. So you're able to access a request form through the website, and that then puts in train a request process where someone within the branch will contact you within 48 hours to formulate your request and put that into our processing train. You can, for those outside of the department, can access through that website, or actually ring that number there to request information. Okay. So now what I'll do is I'll hand over to Steph, who will talk to you about the data sources that we have available in the branch, which you may be able to use for injury research.
Good morning. Before I start, I'll just start by saying that you can ask questions at the end of each presenter's session. Because we're limited to time, we have just 2 questions. And if there's any more, we're happy to talk to you at morning tea or after the workshop session. So just 2 at the end of each section. So I'm going to talk to you about some of the data sources that are available within the epidemiology branch that we can provide information back to you. I'll also talk to you about some of the other sources available and some that you can access yourself. So there's a vast array of health data out there for you to use, and the amount and quality of the data varies depending on what you're looking at. So for us in the department, our administrative data sets, so things like hospital data and death data, are of a very good quality, very well controlled and managed, but they are looking at a small amount of the population, because you have to have gone to hospital or the person has to pass away. So you're looking at smaller groups of people. The further down you go in the data, sometimes it's a little harder to access, but you sometimes are getting a bigger group of the population that you can look at. So we cover both ends of the spectrum here at the Epidemiology branch, with our high-level data within our administrative data sets, and then with our population survey hospitalisation data is available within the epidemiology branch from 1989 to 2011. You have a handout in your pack, and most of the information that I'm going to tell you now is in tables in that report, so don't feel to scribble that away. You have most of it already. So the hospital data is great because it tells you can get the nature of the injury that has occurred. So is it a head injury, back injury, leg injury? We can provide you information on the external cause of that injury. So was it a transport accident, a near drowning, self-harm, a burn, those sorts of things. We can also provide you with information on where the injury occurred, so the place of occurrence, was the person at home or work, and what activity were they undertaking. So that's the sort of information that you can get from the hospital data. While this data set is very complete, there are some parts of the injury data that are more complete than others. So it's worth noting that when you want to look at place of occurrence or the activity that the person was undertaking when they were injured, about 50% of the records that are for an injury say unspecified or specific but other place. So there's a limited amount of information there. However, for the rest of the records, they are well coded, and it still can be useful to see, of the remaining injuries, how many occurred at home or at school, in a playground, those sorts of things. So it's not that you shouldn't use it, but it's just that you should be aware that there's a limit to what we can give you from there. So we also have access to West Australian death registrations, so deaths that occurred in WA. We have data from 1983 to 2010. Here what you get is the underlying cause of death. So that is what external cause of injury caused that person to pass away. So motor vehicle or drowning, those sorts of things. We also have emergency attendance data. It's a little bit different to the other two. It's not quite as well coded. That's available from 2007 to 2010. The metro hospitals and the country hospitals code their data in a different way. So if you get metropolitan data, we can give you the same sort of coding about the nature of the injury as we can in hospitalisation. So was it a head injury, back, that sort of thing. We don't have as many groups for the external cause of injury. They have their own groupings, and they also have some information on human intent. So, did someone cause an injury to the person? It's not quite as well coded as some of the other things. So if a person has an injury, there's only 30% where we don't know if the injury was caused by another person or not. So that's just something else to consider. That we do have the information, but not everything is perfectly coded. The other thing with the ED data is that in the country hospitals they have something called major category. So it won't necessarily be able to tell you quite as much information about the injury. It's more that there was an injury, there wasn't an injury. The good thing about ED data is though that there's the triage category. So you can have a look and see what proportion of people that go in with an injury are most severe, or are mainly lower injury cases that perhaps could have gone to a GP or something like that. So it's still a very useful data source. We also have mental health occasions of service data, which is available from 2001 to 10. Now, while you can't get injury information from there, you can get information about the proportion of people in the population that have alcohol or drug-related mental health problems, and that might help you in some of the projects you run if you're looking at those types of injuries, or if you know there's another mental health condition that makes people more susceptible to particular kinds of injuries, that might be a useful source for you. It's good because it includes both the inpatient information, so what you could get in hospital, and the outpatient services that are provided at public hospitals. So that can be quite useful. These data sets, we can provide you the information by all these different breakdowns. So CIFA, second from the bottom, is a measure of socio-economic status, and ARIA is a measure of remoteness, so from major city out to very remote. So all these breakdowns are possible in the data. What you have to remember is the more breakdowns you want in your question, the smaller the numbers are that we have to work with. And we have a few caveats when you're looking at data, is that we can't provide you information on numbers smaller than 5. So it might be the case that if you want to look at sex and Aboriginality and age, maybe we can only do two of those things together. So maybe we do age and Aboriginality and age and sex, but not all three together so that the numbers are big enough. Or we might have to merge some years together if you're looking at a really small area of the population, maybe somewhere out in the Midwest or something like that. When we run statistics, we also need a minimum number of people in our data set to be able to get a valid statistics figure for you. So that's something else to consider. So when you put your request in, we'll liaise back with you to tell you what is possible and what small changes might need to be made depending on what you're asking, so you get the best possible data for what you're doing. There is some issue with the coding of Aboriginality in data. So usually it is underestimated, the proportion in the data sets that are Aboriginal descent. But we do try to account for that by checking between data sets to get to the highest proportion possible in the data set of Aboriginality coded. But what we do have still demonstrates disparity between the non-Aboriginal and Aboriginal population. So at a more population-based level, we have the WA Local Wellbeing Surveillance System. This is a self-report survey that's done over the telephone. We ask people a wide variety of questions, but those specifically for injury, we have two questions. We ask people if they've had an injury in the last 12 months that required treatment from a healthcare professional, and we also ask if that injury was a fall. So we have that data available for adults for all years that we've run the survey, and for children we've got it from 2007 to 11. This data is for the general population as a whole. It's not representative of small groups, so we can't provide you with Aboriginal data, can't provide you with specific other ethnic groups. It's just not meant for that type of analysis. But what we do is we weight the data so each person represents more people in their area, so we can give you a view of what's happening in the population as a whole rather than just in the sample of people that we interviewed. Now, something else that you might be interested in, this is not what the epidemiology branch does, but if you're interested in some of those health data sets, but you're also interested in some child protection data or corrective service data, main roads data, you want to link some things together, we do have a data linkage branch that runs out of the department. To access this data, you do need to fill in ethics applications. You would need someone to be able to run the analysis for you in your organisation most of the time. But if you want more information on this process, great to go to the website. That's also in the handout. The team down there is very helpful and be more than willing to chat with you with any projects that you might have, looking at how you can link data together and follow people's journey from through the health system and other services, if that helps with the injury projects that you're working on. There are also some data sources out there that you guys can get right now off the internet. So the Australian Institute of Health and Welfare is a great source. If you type in injury into the search engine, a whole bunch of publications will come up. And it's really good at getting an overall view of what's happening in Australia at your national level. The Australian Bureau of Statistics also provides some information on injury. So the National Health Survey from 2007 has a couple of questions on injury, and you can get that down to WA level. And then there are some work-related questions that you also can get at a WA level. So those two catalogue numbers get you to the places where you can get that information. The ABS is also great because you can get your census information, so some information about your population, your demographic, how many are married, what's the proportion of kids, education levels, those sorts of things that can help when you're trying to plan your projects. You can also get some of that off health tracks, which Alex will talk to you about later. But these are sites that you can go to right now and start looking at information. Thank you. So is there any little questions now that people might like to ask for in this next slide? Yes.
What is the self-report CATI? What's the ATI survey?
The CATI stands for Computer Assisted Telephone Interview. It's just how we run the survey. So instead of sending a letter out in the mail with a survey, we ring them up on the telephone. Either Calvin University runs it, and an interviewer talks them through the survey and enters the answers for them while they're on the phone. Yeah. Yes?
What charge category do you use? What system of charge categories do you use?
There are previously, we go to the ED department, the triage nurse will assign 5 triage categories. Yeah, of course, triage category 1 will be you have to treat the patient.
Yeah, I understand.
Yeah.
It's more, is it the Australasian system that you use?
Oh,
Or
yes.
another system?
Yes, that's the standard system we use.
Thank you. So we'll just invite Peter back up now. He'll talk to you a bit about burden of disease data.
Sorry you have to put up with me again. I've come off the interchange bench for this one. So burden of disease is another data collection that we maintain within the Epi branch. It's a very important data set, and hopefully I can make that point as I go through the presentation. So what is burden of disease? It really reflects the impact of illness or disability on the population's life expectancy and quality of life. It's measured by a daily disability adjusted life year, and so the currency of the measurement is time. And it provides assessment of the whole population, not just those using a specific data source. Say if you went to the hospital collection or the ED collection, you're looking at an overall whole population measure here. And it uses estimates of incidence, severity and duration of illness, as well as years of life lost due to mortality. So it has 2 components: the mortality component, which is added to the disability component, and the quality of life component to give the total burden measurement, which is DALY. The mortality is calculated by a product of the number of deaths at the age of that particular death and the life expectancy at that age. The disability is a product of the incidence of a condition, its severity as assessed by societal values, which is sort of one of the controversial things around burden of disease, and also the duration of that disease. What are the uses of burden of disease? Obviously, it's used to compare the impact of different conditions. We can measure or estimate the burden of disease for up to 180 specific conditions, and we can break that down by age and gender. You can also monitor disparities between population groups, so regions or Aboriginal or non-Aboriginal. It allows a measure of the non-fatal health outcomes rather than considering non-fatal outcomes and fatal outcomes separately. It allows us to combine that. It allows us to quantify the burden attributed to risk factors, so we can work out the proportion that a particular risk factor contributes to the burden of particular conditions. It assists in setting priorities for health planning, public health programs, research and development, and even professional training. And therefore it's, helping us to prioritise resource allocation. And some of the information needed to calculate burden of disease through incidence, prevalence and duration also allows us to inform cost effectiveness studies from the information that we developed. So this particular graph shows the major causes, major diseases, and their burden. Not only does it show the ranking of diseases, but also makes another very important point about burden of disease. So you can see cancer and cardiovascular are the leading causes of burden, and most of their burden is made up of years of life lost, so through deaths, maybe premature deaths. Whereas you compare that to the next two, mental and neurological disorders, you can see that the majority of the burden made up for those two is through years of life lost or quality of life issues. And this is the power of burden of disease, because if we just looked at deaths or hospitalisations individually, we wouldn't have come up with the same rankings. We wouldn't have ranked, for example, mental disorders and neurological disorders as highly if we didn't consider their non-fatal component. You can see that injury is ranked very highly. Injury is ranked 5th, and has a mortality component of more than 80%, which is obviously related to premature death, measuring premature death. As I said, we can break down burden of disease into specific conditions, and in terms of injury, there's the list of conditions that we can report burden of disease on. So we can see that for males on the left side there, the dark road accidents and suicide are the major issues contributing to burden disease through obviously premature death, contributing to that death component. For females, road accidents and suicide are there as well, but obviously falls are kicking in, and that's maybe the older age groups occurring, having a lot of falls and contributing a high number. So what data is available for burden disease? Burden disease is actually developed by the World Health Organization through Harvard University, and so there's been several global burden disease studies, but more interestingly there is one, the most recent one is about to be released, and as I've been informed by Erica, the next edition of Lancet will be totally devoted to reporting the global burden disease information. So we all await that. Following on from the global burden disease studies, there's been two national studies included in Australia. One was based on 1996 data, and the most recent data that we have is based on 2003. And based on that information, the epidemiology branch has developed WA burden disease information. So we can provide you with disaggregated age, gender, information down to health region, information based on remoteness as measured by ARIA, socioeconomic status, breakdowns for 5 groups of socioeconomic status, and also comparisons of Indigenous, as I said, across 180 conditions. We also have projections up to 2016, which are sort of coming a little bit too close now, but our basic data is 2006, so that's something to keep in mind. That because we rely on the national study, we've only been able to extract data up to 2006 at the moment. So without another national study, where we find it quite difficult to be able to update our burden disease information because it's such a labour-intensive study to do. And also we quantify the disease burden attributed to risk factors, as you've seen in this report here. The burden disease and injury attributed to preventable risks to health. We use the population attributable fraction method to determine the burden attributed to particular risk factors. I don't think you need to worry too much about the formula. I guess the most important part is that this calculation is based on the prevalence of the exposure to the risk factor in the population and relative risk of developing the condition from that risk factor. So they're the two important bits of information that we apply in that calculation to come up with a fraction of burden that's attributed to a particular condition, to a particular risk factor as applied to a particular condition. We then sum up all the conditions that that particular risk factor may be a risk for, and we get a total for that condition. The information that we've come up with shows that about 30% of burden can be accounted for by those 9 key risk factors. And interestingly, we found that high body mass was the leading risk factor in terms of attributing to burden, even outweighing smoking, which was second. And of all of the risk factors, we can see that alcohol contributes to 18% of the injury burden, the highest of all of the risk factors. We can apply the same method, population attributable fractions, to other data sets. So in the epidemiology injury report, we've done that for deaths and hospitalisations. So this is an example of just applying that methodology to hospitalisations, as we get actually the numbers of hospitalisations that are estimated due to alcohol. So for example, there we've got for males, transport, we've estimated 3,794 traffic accidents due to alcohol, or hospitalisations due to alcohol. So we can do that for a number of other data sets as well. As I said, that burden of disease can be cost effectiveness reporting. We also have a service where we can provide health service costs. Most of these are dependent upon the hospital data, so we use related groups and the cost developed for those to provide costing information for hospitalisations. The same sort of process can be applied to triage categories within the emergency department data to provide costs for ED attendances. We can also advise on the use of cost effectiveness analysis for developing the cost in programs and interventions. And I finally just wanted to finish up with mentioning that there's a new cost of injury report in progress, which Erica's group has commissioned, and I believe that'll be out towards the end of next year. So that's something which is really, look forward to and long awaited within the injury group. So I just thought I'd inform you of that before I finished up. Now I'd like to hand over to Grace to talk to you about spatial analysis. Yes, there's any questions?
Good morning, everyone. GIS is just stand for Geographic Information Systems. It is a computer-based system that combines and analyzes spatial data. So GIS can integrate common database operations such as queries and statistic analysis with the ability to see how data is related to space and time. So consequently, its applications are quite wide. But from the epidemiology point of view, GIS can be used to map the distribution of disease, population at risk, and also can track case histories of the patient. Furthermore, GIS can generate the faster routes between patient addresses and care facilities. And also it can find optimal site for the location of healthcare services. So the GIS can have, GIS allows you to add many layers of information together to give you an overall picture of the issues you look at. So such as the patient, the street, surrounding conditions. So it can help you understand the relationships and come up with some new solutions to the problem you are facing, and you may not thought of the solution before without GIS. So
Road traffic.
So GIS allows you to answer solutions that incorporate the special components such as when do the road traffic injuries occur and which is the fast route for a trauma patient to get to the treatment needed. So using GIS method, we can determine where the traffic black spots are located, and also we can perform the network analysis to determine the faster routes for the patient to transport to the services. So as from the capability, from the function, you can see the GIS have many uses in the health. So today, I'm only going to show you a few cases of our example and give you a little bit flavor of what we can do in the GIS regard. So the main use of GIS in health is in the visual analysis of health data through mapping. Features with the latitude and longitude coordinate can be directly mapped in a GIS. In addition, any of the location information with the full street address, like street number, street name, suffix, and suburb, we can map them into XY coordinate and map them So this is a map of showing the location of stroke care facilities in Perth. And also we can map all the trauma cases in the metropolitan area as well, so we can see where the trauma cases are concentrated. We can also map the most list of the things like this. This map we're showing the average age of the trauma cases in the rural and remote West Australia. So we can see where the trauma cases occur and what age in the different area. And the map on the right is showing the average time of the injury to the first care provider arrived. This is just showing the rural and remote area. So we can just find the service gap, like the red area is the service provided after about 10 hours of injury. So that's just help us planning for our future services. Apart from the mapping, just mapping the raw data or mapping the rates, we can perform a lot of spatial analysis. First one I'm going to show you is just a proximity analysis. We can derive the straight line distance, such as within 5 kilometers of the current liquor license, within a proposed liquor license, how many current liquor licenses are around. Or just like a city council may have environment officer to notify the residents within certain distance of the salt marsh, or just like mosquito habitat area. They close to the water body because close to the water body, the closer to the water body, the more Roseau virus cases occurred in the past. So if there is a season, they have high mosquito breeding, the city council may need to notify the residents around the certain distance. So they need to take precautions of the mosquito bar. So apart from the straight line distance, we can perform nightwalk distance, perform the faster roads, the route distance along the road nightwalk. So this map shows the trauma patient travel to the major trauma center, the faster roads for each of them travel to Sir Charles Gardner Hospital, it's a major trauma center. The map on the right derives the travel distance by road. Just like it's a 5 kilometer spaced travel distance. So we can see most of the people, some patients that can get into the major trauma center in the metro area in time. We can also do the density analysis because mapping the density of the feature allows you to see the patterns of where these are concentrated. We can map how many people within a certain area, but we consider the density, consider the area, so it gives us the best picture. Let's see how people are concentrated, which area have more people, so we can plan our services accordingly. We can also perform the port density analysis. This is the map we performed for our workforce planning division to relocate our doctors from current Ropers to Fiona Stanley in the future. So we performed to see where our young doctors live and where our old senior doctors live. So give our workforce division informed decision, informed data for them to make the decision a bit easier. So we can also allow you to map the data in time and space. So we can track where things move or the changing conditions and in a place over time. So I'm showing a few examples from 2011 census. So this is just the map showing our 65 plus population in 2001 census and also 2011 census. So as you can see from the map, we are getting older. And also this is the map showing our younger population, 0 to 4-year-old, from 2001 and also 2011 census. We have more babies. And this is the comparison of the 2001 low-income families and 2011 low-income families. We use the cutoff of 300 weekly for 2001, 400 for 2011 for the family household income. So it's from the map on the right is latest information we are getting for. Sorry. And we can also perform hotspot analysis. Like we can map the patterns, we can map the point dot on the map, but that doesn't really tell you anything, tell you much information. It's just like some point on the map. But we can do a quite sophisticated hotspot analysis, try to see the patterns where things are really concentrated. And also because hotspot analysis allows you to see the neighborhood as well. So it's really give you a better picture than just the single map. So my final example is just like give you the example of what we do for integrate all information together to find an optimal location for a new health facility. This is just like for a new child health center. So this is just an example, but we can use this method for for planning any of health service locations. So the first one is we just choose variable of interest, such as current child health centers and the birth rates, public transport routes, everything. And we record each variables to a common sense, common scales, and then we weight the variables according to our need. Then we combine the variables in the GIS. This is the beauty of the GIS. It can combine lots of information together to give you a suitability analysis map. So this is the result for the Ellenbrook area. So the red area is more suitable for the new child health centers. So that's how much.
Do you map only public government-funded services, or can you map like private services as well?
You can have any,
Okay.
as long as you have the address.
Oh, sure.
Yeah.
Okay.
Next, I'm going to talk about the epidemiological measures and how we can present epidemiological information. As Peter just now mentioned, because the demand for epidemiological statistical information is immense. We receive lots of data requests every day. So we need to have a way to provide information in time, in a quick and efficient way. So that's why we have developed a health track reporting tool to provide information as much as we can, as quickly as we can. And currently, the health track reporting tool is available to all health department employees. Of course, if anybody from outside of the health department want to have access, so actually you can contact us and we can discuss to say what sort of accessibility you are allowed, and then we go from there. So now I just want to show you the availability of those reports available in the health track reporting tool, and what are the measures can be derived, how we can interpret those measures. So here you can see that I put together all the injury-related reports, which are available from health traffic reporting tool. And also from the top, you can see there are 7 reports. The first one is general health profile. Actually, this table is available in your brochure. Yeah. So the first one is the health profile. Basically, this report contains 2 major pieces of information. The first one is the latest census data. That's 2011 Australian census data. From there, later I'll show you briefly what is included. The second piece of information is the preference data. Just now, staff mentioned. So basically, this type of information is quite important when you try to analyze a particular type of injury. This information will provide you some background information. The second report is a health topic overview report. So basically, through this report, you can compare with other non-injury categories to see whether injury is more frequent, and just compare other categories. The third report is health condition overview. So basically, you can use this report to compare different types of injury. The fourth one is leading health condition report. Basically, this report will provide up to top 15 conditions. So if we, for example, we have lots of injury types, and you can use this report to identify the top 15 injury conditions. The next one is specific health condition analysis report. So basically, you can drill down. For example, I'm interested in a traffic or transport injury. That's a broader category. We call it a major category. And if you want to know, what happened to motor vehicle accidents? What happened to those hospitalizations due to pedestrian accidents? So through this report, you can drill down to say a specific condition, a specific injury, and find out what happened in a particular geographical area. The next one is Aboriginal, non-Aboriginal comparison. Basically, within the same region, for example, within North Metro, are there any difference between Aboriginal and non-Aboriginal population in relation to a big major category of injury or minor category of injury? So this report can provide such information. The last one you can use is the area comparison. As you know, in WA we have 155 statistical local area. We have 34 health districts. We have 9 health regions, 4 area health service. Basically, North Metro, South Metro, Country North, Country South. So we have 4 area health services. So by using this area comparison report, you can compare among different geographic areas. For example, you can produce a report, compare all 155 statistical local areas to see are there any differences. So on this side, you can say within the health